Thank you for being here at this early time for the Uveiti session. There are two sessions, one after the other, that is organized with the Italian Uveiti Society of Chronic Disease and the iOS Society. So there are two very important topics this morning. One is the treatment and clinical features of Uveiti macular edema. That is one of the most threatening complication of many retinal diseases, including uveitis. And the other will be on the new frontiers and new development for the therapeutic approach of uveitis. So with my co-chair, Professor Nguyen and Professor Desmet, I think we can just start with the session. And I would like to invite Emanuela Interlandi from Naples, who will speak about the clinical features and ancillary tools employed in managing Uveiti macular edema. Please, Emanuela.
Hello, hi Massimo, thanks to the chairs. So, macular edema is defined as the pathological accumulation of fluid in macular space, and this can follow three different main patterns, like cystoid macular edema, diffuse macular edema, and serous retinal detachment. In uveitis, inflammatory tissue and the release of inflammatory factor may produce edema through different pathways. The first one is the direct damage of the retina. The second one is the breakdown of inner blood retinal barrier. Then we may have breakdown of outer blood retinal barrier. And lastly, the stretching of retinal layers and blood vessels. The first two mechanisms are more frequent in anterior uveitis, intermediate uveitis, and panuveitis. And principal pattern related to these mechanisms is cystoid macular edema and diffuse macular edema. The third mechanism is much more frequent in posterior uveitis and may produce mainly the serous retinal detachment. Stretching of retinal layers can occur in all kinds of uveitis if complicated by ERM or VR traction. Uveiti macular edema is the first eye-treating complication of non-infection uveitis and can occur in up to 10% of the cases. According to the literature, the kind of uveitis that most frequent is complicated by macular edema is the intermediate uveitis, where we have this complication in up to 75% of patients, followed by panuveitis, posterior uveitis, and lastly anterior uveitis. Here you can see three different kinds of anterior uveitis, and in all cases, these CME are a complication. So this is the main kind of macular edema we can see in anterior uveitis, and whenever the inflammation reaches the retina from the anterior pole or the anterior chamber of the eye. In intermediate uveitis, we can have a mixed pattern of edema because we have mixed pathways or mechanism of producing macular edema. So we have a case of intermediate uveitis with cystoid macular edema and serous retinal detachment. Once again, in the middle, an idiopathic intermediate uveitis with cystoid macular edema and serous retinal detachment. And on the bottom, the last case is a very severe phenotype of vasculitis complicated by both cystoid macular edema and CMV. In posterior uveitis, the pattern, the type of edema more frequent is serous retinal detachment, as you can see in these three different cases: VKH, intraocular tuberculosis, and RPE. In panuveitis can play a role wherever kind of mechanism. So we can have diffuse macular edema, cystoid macular edema, or mixed pattern, like in this last case of ocular syphilis with serous retinal detachment and cystoid macular edema. Persistent macular edema can lead to retinal ileosis and atrophy, and if untreated, it can result in a permanent vision loss of patient. That's why we need to treat very soon and aggressively this kind of complication. And our therapy has two main goals. The first one is the prompt management and resolution of macular edema. The second one is the treatment of the underneath ocular inflammation, so uveitis. In case of non-infection uveitis with unilateral involvement, isolated ocular disease, mild phenotype, or recent onset, we can start our therapy with steroids alone, achieving both macular edema resolution and uveitis treatment. In case of non-infection uveitis with bilateral involvement, systemic disease, severe phenotype, chronic course or high risk of neovascularization, we can start with steroid for a prompt resolution of macular edema, but then probably we need to start immunosuppressant or biological agent to have a properly control of uveitis and ocular inflammation. Infection uveitis like TB, syphilis, herpes, toxoplasmosis, or others, we need to start as soon as specific antimicrobial therapy, and then we can associate 48, 72 hours later oral steroids to achieve the macular edema resolution. So this is an overview of our therapeutic approach, just to remind that in both kinds of uveitis, non-infection or infection, if we have neovascularization, we have of course to consider a proper therapy with anti-VEGF, or if we are ERM or ear traction, of course we have to consider a specific macular surgery. Thanks for your attention.